Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding, dark, oxidized earwax, and I'm just commencing with this their left ear. The wax in this ear, as you can see, it's quite soft and glutinous, which can make it difficult to suction. Therefore, in a moment, I'm going to instill some medical grade olive oil spray. And what the olive oil spray does, it helps to bind the wax together. As you can see, I've just put the oil in there. Makes it a bit firmer. So when you do suction the wax, it comes out in bigger chunks. It also helps to prevent blockages. When you've got a consistency of wax like this, as you're suctioning, this wax, as it's traveling up the suction tube, can block the internal hollow section of the tube. So with a bit of olive oil, it helps to lubricate the inside of the suction tube as well to help prevent and minimise and limit blockages. Just working on this is the portion of the ear we call the posterior lateral aspect of the ear canal. So essentially it means when you enter the ear to the rear, right near the entrance, quite often you can get a blind spot there, and it's only until you remove and release the wax off the canal wall in this section that you can then release the remainder of the wax. I'm just being careful just to avoid making direct contact with their posterior canal wall, their back part of the ear canal, because this wax, as you can see, is stuck to it, and there's always a risk as I'm trying to lift it off the canal wall that I embed the suction probe too deep, and that will make contact with the canal wall and be quite uncomfortable for the patient. I've removed possibly around half of the earwax, and I've just decided to instill some more olive oil spray to bind together the more medial wax. When we say medial, we mean towards the eardrum, away from the entrance. And again, I'm just trying to peel this off the back part of the ear canal. It's just slightly blurry, and the reason for that is I'm suctioning whilst the drops is in situ. When I first started using drops during my procedures, I used to allow it to settle and rest for a few minutes and then drain the ear. So to drain the ear would get the patient to tilt their head in the opposite direction from what you've instilled it with. So in this case, it's been their left ear. They will tilt their head over towards their left shoulder, which would mean that their ear will be facing the ground, and you'll just allow the oil to drain and drizzle out. But the more I'm using drops during procedures, I like to perform it wherever possible whilst the drops are still there, so I've not drained it. I just find that I get a better suction grip and it's less likely to block. But one of the negatives of that technique is that you can get occasionally blurring, because as you're suctioning, you're also suctioning some of the oil, and that oil will hover over the lens of the endoscope and therefore refracting light and causing a slight blurry image. So we've just got this little bit of wax left really deep right up against the eardrum in the anterior recess. You can see the eardrum around the edge, on the posterior edge, the blue tinge. And then I'm just going to bring this away slowly. A little bit of the wax just broke off on the roof of the ear canal. So I'm just going to mop that up. So this patient's ear canal, it is somewhat slit in appearance. And when I say slit, all of our ear canals, the height of the ear canal should be greater than the width. So it's an oval shape. I would say this patient's height is probably a bit proportionately greater than the width than the norm, which gives it more of a slit aperture, so more of a narrower, elongated shape. It is also quite bendy. You can see the eardrum, it veers off to the left. And when you've got a bendy ear canal, sometimes it's just a bit more difficult for the wax to naturally migrate. I'm just using the fine end suction probe here just to hover over all this wet residual wax. So this wax is not clinically significant. It's not going to affect the hearing, and it's not going to cause them any symptoms. However, the patient does wear hearing aids, and I just want to ensure that when they insert the hearing aids, it's not this wax. It's not going to occlude and block the sound bore of the hearing aid, so it's going to cause malfunction, failure of the hearing aid. So I'm just trying to remove as much as I can, but we've just got to be careful not to put too much pressure on the ear canal, because that will be uncomfortable for the patient, and that's the last thing we want. So we're just on the back part of the ear canal. You can see this wax is really sticky. There's a bit of dead skin in the mix as well. And the key is just to hover over, just trust the suction, allow the suction to move away the wax. Now we're on the cartilage portion. We can put a bit of pressure here. The cartilage portion is more flexible and less sensitive than the bony part of the ear canal, which is the inner two thirds. See, they've got this bit of dry crusted skin here. Just leveraging that off. So it's just got a little bit left here still, and that is on the bony part, so it's going to be a bit more cautious. I've just bent the tip of the fine end towards the back part of the ear canal, so it just gives me a better angle to work with. Slowly but surely we're peeling this away. See that fresh layer of dead skin that I just suctioned. It's just died and it's just shedded. And we're just going to mop up now near the entrance. This patient has to attend yearly. It was almost a year to the day since they last attended, so they are a perennial earwax sufferer. Over the years, they've found that they produce a lot more wax. I would suspect that they possibly produce the same amount of wax. However, as we get older, it's more difficult for wax to naturally migrate. And that could be for several reasons. It could be, as for most people, as we get older, the skin that lines the ear canal gets a bit drier. The skin cells are less able to retain intracellular fluid. So it gets dry, and that can cause friction as the wax is trying to migrate out of the ear. This patient's earwax is a bit sticky, and it could be over the years. Again, we would expect earwax to be dry as we get older, but in this patient, the wax is still quite soft and wet, but it's tends sticky, so it could be that the consistency has changed from a more fluid, less sticky consistency. And as this wax is trying to come out, it's sticking against the canal wall. Of course, I mentioned that they wear hearing aids, and wearing hearing aids can inadvertently push the wax further in. So this is their right ear. This wax is a bit firmer, actually. It's also a bit darker, so it's been in there longer. When they last attended a year ago, there wasn't a significant amount of wax in their right ear. In fact, there was such a minimal amount of wax. There was some wax, but it was what we call non-occluding, so we decided against removing it because it wasn't impacting against the patient's hearing aid use, and it wasn't impairing their hearing. So this ear, in a way, it's got a head start, and the wax is therefore, what wax was there was just become darker, it's oxidised. It was a lot firmer, so it came out in a large singular piece. That's the patient's eardrum. You can see it veers off to the right, so it's quite a sharp bend towards the eardrum. And once more, I've attached a fine end suction probe, and we're just going to now mop up around the edge. So the fine end suction probe provides more finesse, low level suction. It's got a smaller internal diameter, and it's also shorter in length. So it is, in essence, less powerful, but when you do apply it to a certain part of the ear or the wax, it can have more suction power, because when you have lower surface area, you've got greater pressure. So I wouldn't be fooled by the size. Sometimes it can be quite powerful, especially when we're suctioning dead skin. I find that once you've got a section of skin that you want to vacuum, it really does attract the skin towards the suction. With a fine end, you're less likely to get clarinetting. So you can see there's a bit of skin here that's just really got attracted to the fine end suction power, because it's more localized. With the Zollner, the standard size Zollner suction probe, the internal diameter varies between 1.7 and around 2 mil. So it's a greater surface area. So that, although it's got greater suction power, it's spread across more of a surface area. And I'm just mopping up near the entrance. You can see this is similar to the left. It's quite slit. It's elongated in shape, and it's very bendy. It's a bit more narrow with this side. I would expect this ear to be more waxy because of that. Their left ear was narrow, but not as much as their right ear. So this is the cartilage portion, so we can put a bit of pressure on here if we want. And now we're on the border of the bony part. You can see that change in texture and consistency of the skin. The bony part's more pale. The bony part of the ear canal is just a bit more pinky, more red, whereas the cartilage portion is just a bit paler. And so the paler skin is where the cartilage is, and the more redder change in complexion is the osseous portion, the bony part of the ear canal. So again, this is the cartilage portion, and we're just hovering over the bony portion there. So that's probably on the bony part, back to the cartilage. So it's the outer third of the ear canal, typically that's made up of cartilage, and the inner 2/3 is made up of bone. Yeah, this patient's got a bit of a blind spot to the rear of the entrance. So just a bit on the bony part again. Just going to hover over it. All this is all bonus. We wouldn't, when we train our clear wax specialists, we would say in normal circumstances just leave all this. But as I mentioned, the patient does wear hearing aids. I just want to avoid the wax as they're inserting the hearing aid into the ear, blocking the sound tube, so reducing amplification, causing potential malfunction of the hearing aid. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Thank you. Bye.